patient was a 9-year-old female with history of fall on outstretched hand. There was swelling, deformity in the right hand, and no neurovascular deficit was seen. The patient was operated with closed reduction and internal fixation with cross-K wiring fixation 6 months back. Immediate post-op and pre-op and post-op X-rays are as follows. This was a reduction which was achieved just post-operatively. The patient was then followed up, and after 1 month, the KYs were removed. The patient then ended up after 6 months, and then this was the X-ray which was post-operatively seen. 6 months post-op. At 6 months, this was the X-ray. Due to the angulation and the deformity of the radius, we had then planned out for an open reduction and internal fixation after doing an osteotomy and fixing it. So what is the plan of action now? We had already planned it out and then fixed it. The patient was surgically managed with osteotomy and open reduction and internal fixation with fascial sparing plating. This was the post-op X-ray which was done. The physis was spared, and there was no, our main goal was to minimally invade the fracture, and also that was the reason the third cortical screw was not put up in the proximal fracture, piece. So my outcome and conclusion: patient had an uneventful recovery. She had a good functional outcome on recent follow-up. The discussion is that should an open reduction and closed reduction be done, or an open reduction which is favorable for internal fixation when the patient presented first, which we always know that we should go for closed reduction, but still in this fracture patient, since it is an patient which is to be done, so take home message is challenging to treat the first distal radius fracture, which approximates to distal end radius. It is difficult to hold the fracture reduction, so better to fix the fracture with cross-K wiring, appropriate size tensionate, and fascial sparing low profile plate. However, the approach to this fracture depends on the surgeon discretion on choosing the modality best suited for reducibility and maintenance of fracture reduction. Thank you, sir.